Good evening, everyone, and welcome to tonight's webinar. My name is Anne Hughes, and I would like to welcome you all to the final instalment of the low-level laser therapy webinar series. We appreciate your time this evening and for you to join us. Tonight's webinar is being recorded, and you will receive a follow-up email with a link to the recording. Please feel free to share the link with your colleagues that probably are unable to attend this evening. This evening we will be taking a Q&A. We would ask that you write your questions in the chat box so that we can take them at the end of the presentation. If we are unable to answer your question this evening, we will respond to them via email. We will get through all the questions, no matter what happens, but we will run over time. We know that because there's lots of information to share with you. But yes, please use the type box to ask the questions. Before we begin, I would like to acknowledge the traditional custodians of the land on which we gather today and pay my respects to their elders past, present and emerging. I extend that respect to Aboriginal and Torres Strait Islanders here tonight. I would also like to acknowledge the traditional owners of the land which you are on tonight. And without further ado, please welcome Brett Jarosz, our presenter for tonight. Over to you, Brett.
Thank you, Anne, for the introduction. I will just get this screen up and running. Okay, so the third of three of the low-level laser therapy webinars, finishing today with what a number of people have sort of requested, which is looking at more of the clinical application. So looking at how do we actually use this clinically? What does it look like? And obviously try and present you guys with the actual research and evidence behind that, as well as then just obviously going through some demonstrations, sharing some case studies. We've got a couple of really good case studies to share with you tonight, and sort of I'll give you a bit of a background and share my journey actually as to how we ended up here today. So disclosure, same as last time. I'm not an employee of Acne or Rehab Care, but I'm just a vendor and consumer of the products that I utilize within my clinical practice. And the big ones that I really want to emphasize today, remember that this presentation is not intended to diagnose, treat or cure, and I should say any medical disease process. Clinical and research information provided is intended to support the normal adaptive physiology of the human body. That's really prevalent as we start to talk about these case studies today, because certain treatment applications I'm going to demonstrate later on today, they are off-label to a degree in relation to FDA approval, but all the things I'm going to present with you guys today have got research to support the treatment applications, but always remain within your scope of practice for your particular profession, as well as for your region of practice, jurisdiction, country, state, etc. So far, webinar one, we went through those overview of the scientific mechanisms and we introduced the EVRL. Webinar two, we started to go through the differences in the technologies. So using laser, infrared components of laser, low-level light, LEDs, class 4 lasers, etc., and started to introduce some more of those evidence-based applications of the EVRL. And then tonight, we really want to get into those advanced clinical applications. So we'll hit the high points, review those mechanisms, my bias in practice, however I practice with whatever tools, whether it's manual therapy, some form of physiological therapeutic such as the EVRL. I want to understand mechanisms, the physiology, because I want to understand those components so that way I have a greater probability of being able to choose which modality I might want to use to try and help patient management, to try and help improve their outcomes. I don't care what people use to help them get better as long as they're getting better, but I prefer to understand how something works so that way I can use it in the future and I have probabilities of having success with that, or increasing the probabilities of success by understanding those mechanisms. So we'll review those mechanisms, we'll review those differences between those technologies in case there's been people who have missed webinar 1 and 2. I think it's super, super important, again, because if you know how to do that, then you can use any types of therapies off-label, because we understand those basic scientific mechanisms, and then we'll go through those advanced applications today. So I want to hit through these at a pretty good clip, because the cases obviously some of these are things are worth more than some of this academic aspects of it. So our first law of photobiology is that for low power visible light, and we'll talk about that spectrum again of visible light, to have any effect on visible light to have any effect on living biological systems, photons must be absorbed. So the energy from the light must be absorbed in order for it to have a photobiological effect, or the word we used in the last webinar is actually that photochemical effect. So absorbed by some form of photoacceptor, chromophore within those cells, within the tissues. And so remember, it can either be absorbed or it can be scattered. And we talked about last module about how LEDs have a greater ability of scatter because they're not in that directional coherent aspect. We'll review that again in a second. So we've got to have photons being absorbed. That is our first law for light to have an effect, got to be absorbed. Then the physical mechanisms we talked about, the energy of the wavelength, and we come to that picture again here over on the left of the screen. We can see that as that wavelength gets wider, longer, increases in wavelength, there is a corresponding decrease in energy. As the wavelength gets shorter, we can see that that wavelength of energy increases. So if we match that up to the different types of wavelengths, from radio, obviously we've got a longer wavelength, there's less energy with that. And then we move to microwave, we get to the infrared, then we move into some of our, of course, diagnostic types of things, X-rays, into the gamma rays. But our visible light spectrum fills in that small gap through there. We can see that the thing that has more energy is on the blue end of the visible light spectrum and less energy on the red end of the visible light spectrum. But the energy of an individual photon depends only on that wavelength, as we said, through all of those different wavelengths that we've got, radio to gamma rays. And then if we're looking at the visible light aspects, we know that blue photons have more energy than green, that have more energy than red, that have more energy than infrared, etc. We talked about in module 1 and 2 about the wavelengths and the mitochondria, and inevitably low-level laser therapy or light therapy, if we use that umbrella term, photobiomodulation, inevitably affects and involves the mitochondria. The one that's got all the big research behind it here is complex 4, so cytochrome C oxidase or COX. We're saying the same thing, just all the different terms that can be used. And a lot of the earlier studies, because of the historical nature of that helium, neon, the red light, colored lasers, red light has its effects on complex 4, on cytochrome C oxidase, COX. But we started to talk about how violet has impacts on complexes 1 and 2, and now we're starting to see that that green emerald light has an impact on complex 3. We know that if we influence the mitochondria, we start to influence that respiration chain. So we start to get increases in oxygen consumption, increases in membrane potential, and enhanced synthesis of NADH and ultimately ATP. So wavelengths, the light absorbed by the chromophores, the colored lights get absorbed by different complexes within the mitochondria. And that, of course, helps that electron transport chain produce energy, produce our cellular energy, which is ATP. And then our key aspect of energy and that biphasic dose response or hormesis that we referred to, old terminology was in this light therapy world, even in the drug world, was that Arndt-Schultz law. We now more commonly know that's in today's day and age as hormesis. So we can see here, it suggests that if insufficient energy is applied, there will be no response. If we look at the graph in this bottom red component here, this flat line, if there's not enough energy, there is no response because the minimum threshold has not been met. And then if more energy is applied, then a threshold is crossed and biostimulation occurs. So we can see, obviously, this is starting to come up. We're getting enough energy into the cells. It's talking about 1 joule per centimeter squared down here, then 2, then 10, etc. So we can see that as we get enough energy, thresholds cross, stimulation occurs. But here we can start to see we're getting to this sort of ultimate point up through here of the ultimate amount of energy being absorbed that we can use for biostimulation. But if too much energy is applied, then the stimulation starts to disappear. And then if we go even too far, we then get bioinhibition. So we're getting detrimental effects. And in this particular study, you can see that this is starting to happen at about 10 joules per centimeter squared. We talked about when we want to go really simply, wattages. So the power of our light therapy devices, 1 watt is the equivalent of 1 joule per second. So when we're looking at energy, 1 watt is 1 joule per second. So the other way to look at that there, it says 10 joules per centimeter squared, that if you had a 10 watt laser, you would impart 10 joules per centimeter squared with a 10 watt laser in 1 second. Okay, so 1 second of treatment with a 10 watt laser is going to be 10 joules. All right, so understanding this biphasic dose response, that we want to create enough stimulation, we want to be in this up part of the curve and not wanting to be in this downward part of the curve, and definitely not wanting to be coming down here where we're getting detrimental effects. We're trying to use light therapy as a positive aspect of therapeutic response, obviously not in a bioinhibition response. So the review of different technologies from webinar 2, want to just emphasize this part again when we talked about this visible light, because we wanted to talk about photochemistry. Second slide we just reviewed in that last section talked about wavelength is the thing that matters. The color of the light is the thing that matters. And so when we look at the energy of a wavelength, we can see the 405 nanometer, which is the violet from the EVRL. So 405 is violet. We can see that that has 3.06 electron volts of its photonic energy there. The 532 nanometer, that's the emerald from Zirconia. I'll touch base on that a little bit. So that's the green-blue type color. We can see that has 2.33 electron volts. Then the 635 nanometer, again, that is the red that's in the EVRL. That is the red wavelength that's used across all of the Zirconia devices. That has 1.95 electron volts. And then our 830 nanometer range tends to be our classic infrared ranges. So once we start getting over that 700 nanometer range, we're starting to talk about moving into that infrared, as we can see through here in that. So once we get past that 700 range here of this visible light cone section, moving into that infrared. Now, as we can see at the bottom, a 405 nanometer has 70% more energy per photon than an 835 nanometer infrared wavelength. But why this becomes important is for photochemical effects. So for light to have photochemical effects within our tissues, so within the cells, within the tissues, we need 1.7 electron volts. So basically, we must start to see that red visible light, and most of the research is in that 630 to 660 nanometer range for that therapeutic effect. And we can understand why when we start to look at those electron volts. So some of those reviews from the photochemical articles. So visible and infrared both affect biostimulation, but in different ways. So visible light elicits photochemical changes because of that electron volt component, whilst infrared can only produce physical changes. And then we'll break that down again into the next quote, which is visible light can produce photochemistry again, but infrared radiation only produces molecular rotations and vibrations. And as we'll go to in the next slide, in particular, water. Water absorbs infrared. So it said for therapeutic effect, we've got to absorb the light, absorb the photons, and water is what absorbs infrared. And then we'll start to think about how the human body's structured. And most of us are, depending on what research you read, let's just say 70+% water. Infrared's being absorbed in water, causing those water molecules to vibrate and oscillate. And then, as we talked about last module, and now we're talking about it today a little bit further, that's what creates that photothermal heating effect. So visible light imparts photochemical changes. Infrared light creates physical vibration, rotational oscillations. And we talked about it last slide, considering the low quantum energy per photon for the 785 to the 905 nanometer range, so infrared, that is equal to 1.52 to 1.37 electron volts. They apparently do not induce photochemical effects, as the minimum quantum energy is in the order of 1.7 electron volts. So visible light is powerful enough, the energy, photonic energy, is powerful enough to induce those photochemical effects, whereas infrared does not have enough of that energy to have those photochemical effects. Instead, it has those photothermal effects. Then we get into that discussion of wattage, the power of our different devices that we're using. So what is increasing the power change? Because the argument, which we'll touch on it coming up again soon, is this depth of penetration. We need more power to get the light to be able to penetrate deeper. So by adding more power to the laser or your LED, whatever you're using, all you're really doing is, so if you've got a bucket of red, so 635 nanometer red wavelength, if you've got a bucket of that, by adding more power to it, all you're doing is adding more buckets. Okay, so you're just adding more and more buckets to basically throw at the person. Changing the power is not changing that 635 nanometer. All right, and as we talked about, the absorption and the penetration, I'll use another slide coming up in a sec, that's all got to do with the wavelength. That wavelength is what's generating the penetration through our tissues. So increasing the power does not increase the depth of penetration. It's just getting more buckets of the same thing and throwing more of it at the person. All right, so that depth of penetration, this is a great example, and we all experience this, we understand it if we use water. So when we look at water from the sun, you know that on the top of the water, when it's been a nice sunny day, the top of the water is warm, but the deeper you go down into the ocean, the colder it gets. So the top of the water is warm. Why? Because infrared is absorbed at the top, and that's where we get those rotational, vibrational mechanisms occurring, heating of those tissues. That rotation vibration creates that photothermal effect. So here we can see the visible light spectrum is too energetic. So that photonic energy, previous slide, that cone of energy that we saw, 405 nanometers has the most energy. We can see over here, that violet, this one here has the most energy. We can see how that's penetrating through water. We can see here through our blue and green, how these are penetrating quite deep. And I think of the color of the ocean. All right, the deeper you get, the bluer, greener it gets, okay? So it makes sense when we use water as that example. So the infrared light spectrum exhibits strong absorptions from vibrations of the water molecule. The result of infrared absorption is heating of the tissue because it increases that molecular vibration activity. That's our photothermal effect. And so for any of you that have had infrared, i.e. infrared saunas, infrared laser, that we know that with an infrared laser, we have to keep moving it because of the heating of the tissue. If you keep it on that one spot, you can naturally burn people because of that photothermal effect. Then we started to talk about the LEDs and broadband light from last module to what is different between an LED versus LED, because we know that we're using LEDs as part of photobiomodulation therapy. So the light absorption doesn't depend on that spatial coherence. If we look at the picture here, we've got our normal sort of flashlight. Then if we come down here, we put a red filter, which is making all of the light become one color, one wavelength here in this particular case. But as we can see here, that particular light is not in one direction. It's going in different directions. What we want is, when we look at laser light here is that directional, and we've got monochromaticity. So I can't even get the word out. So we've got the one wavelength there, we can say that. So monochromaticity is much more significant when it comes to looking at light therapy. So illumination from the laser is absorbed several times more actively than incoherent light with a larger spectral width. So that narrow width of light coming out of a laser is absorbed better than when we have this wider range of light that's coming out. Does LED still work? Yeah, we've talked about it. We'll review that again. LED works. It's just that laser, having that very narrow directionality to it, is absorbed by the tissues. And we said absorption is the key when we're using light therapy. When we have scatter is the thing that is basically wasting the opportunity for those photons to be utilized. So if we looked at the Erchonia pain studies, so 5 double-blinded studies, what we can see here is the dotted line is the sham group. The sham group in all Erchonia studies is using the same wavelength in an LED. So we can see here, this particular group is the group that was receiving the 635 nanometer wavelength. Now this is a summary of all of the pain studies from Erchonia. So this includes comparing the shoulder pain study, the back pain study, the plantar fasciitis study. And this includes obviously comparing LEDs in each group and the laser from Erchonia in the other group. So what we can see here is that if we looked at the reduction in pain, LED gets a reduction in pain, but it doesn't get the same reduction in pain as the laser does. And as we get, because that directionality, so even though that's the same wavelength, so 635 nanometer, we said that the wavelength is key, but then that next layer is by adding that directionality to it, allows for greater absorption of that wavelength. So LED, yes, it works, but because of that wider spectral width of it, so it's being dispersed out, there's more scatter. So more scatter means less absorption, and absorption's key. Laser is what allows you to get greater absorption. So we can see that. If we look at the other slide here, what became interesting is if when we followed up the pain groups 2 to 4 months post the treatment, what we can see with the laser therapy group, obviously we got the change here. So they got that improvement, but then the people after treatment had ended right here in the middle, we can see that people continued to improve even after the treatment stopped, because obviously that light, the photochemistry, is imparting that adaptive physiological changes. So we're getting those mitochondrial energy production changes that are occurring with the laser. But what we can see here with the LED is the LED, basically, you can see you got better while you were using it, and after you stopped using it, you started to regress a little bit. So that's an interesting little finding there. But the key takeaway message is that the absorption is key, and that differentiating factor from LED to laser is that directionality, that narrow bandwidth of, I don't know if I used the right word there, but that narrow directionality of the laser compared to that broad, wide aspect of the LED. Now, the Erchonia fat loss studies, this RehaCare are a distributor of the Emerald laser, which has got TGA registration in Australia and FDA clearance. It's the only non-invasive device that's out there for fat loss. Erchonia is doing more research. I will probably do a few webinars coming up in the new year on the Emerald colored light, so that 532 nanometer, and how that works with fat loss. But the purpose of this particular slide, again, from the research, is to show, again, the sham is LEDs, and we can see you get 6 times better results with laser than you do with the LED. So exposing people with the same wavelength, LEDs, to lose body fat. We can see there in that gray. And then that was, of course, the changes here with using the laser. And then again, same thing across the top is the LED group. And then down the bottom there, of course, is the laser group, regarding those changes of how much reduction in circumference through fat loss. Then we talked about the FDA clearance aspect as it related to class 4 lasers. So, and again, when I was going through a lot of these aspects, I'm going to share the case study that put me on this path to why we're here today. And when I started looking into some of these components, again, these were all the fascinating things that appeared to me in this confusing umbrella of that term photobiomodulation, and how we have LED, low-level laser, infrared laser, high-intensity laser, all this, etc., under that one umbrella term of photobiomodulation, but it's all different, even though it's under that one label. Like many a thing in healthcare gets put under this umbrella, but we need to be a little bit more specific. So class 4 lasers are cleared under the ILY product code. And what that category is it was a heating pad, and that expanded to thermal lasers. And what they are intended to do is to provide topical heating for the purpose of elevating tissue temperature for temporary relief of muscle and joint pain and stiffness, arthritis, pain, or muscle spasm, the temporary increase in local blood circulation, and or promoting relaxation of muscle. FDA has now made the ILY products 510K exempt, just a code they use based on the device requirements of raising skin temperature to 40 to 45 degrees. So we said last module, skin's 95%, the dermis is 95% water. We know that infrared light, which is what these class 4 lasers primarily use, they're using these 800, 900, 1000 nanometer wavelengths, so infrared wavelengths. So naturally that's being absorbed in the dermis of the skin primarily because of the water molecules, creating that rotational vibration aspect. So we create that photothermal effect, that heating effect. So that when we look at that category there of what it does, it provides topical heating. So we're getting topical heating, and we know that obviously heating tissue, whether you use a heat pack, a hot water bottle, infrared, etc., we can get that temporary relief of muscle and joint pain, stiffness. So again, different mechanism, infrared versus low level laser, photothermal versus photochemical. But again, class 4 lasers, what they're cleared for is what's listed there. So it's the same as advertising something in your practice to say that you've got evidence to say that something does something. A class 4 laser, this is what you've got the evidence to be able to say it does. It's temporary relief via topical heating. So advanced clinical applications, I guess the bit that we've all sort of really been waiting for as to how do we start to use this device and what can we start to use it for. Share some evidence with you guys today about what the evidence is, and there's a lot of it, but I want to try and keep it specific where we can just to the EVRL because that's the device, but I want to start to share some of these sort of off-label aspects where we've got research, but I want to give you some clinical sort of applications that myself and colleagues have developed to use to, I guess, a little bit more greater probability of success. So before I get into that, though, I want to share my personal case study to demonstrate how I ended up here today. So before we start, I was not a laser person, didn't have one, had never thought of getting one, to be honest, didn't really want one. And there's a case study I'm going to share later on today from a colleague who, similar story, he knew I got one of these. He had no intention of getting it. Got one from Reha Care. And to be honest, he was getting it just to trial it with no intention of buying it. And once he started using it, he called me up and he said, how can I not buy this now? We'll share the case study and you'll see why he made that call. But I've got colleagues that are involved with Zirconia in America, and I've been chatting to them. They use their devices in their practices, and even with colleagues that were using it, I wasn't convinced until this happened. So this is my daughter. So this was the start of this year. So 11-year-old female, she was at basketball training, just doing a normal drill. She basically ran in, stride stops her. They got the ball dribbling and they just go 1-2 and land 1-2, maintain balance, and then they're going to work on a shot, pass, pivoting, etc. So standard drill. nothing out of the ordinary. There's nothing bad there. No defenders, no contact. She just went 1-2. She felt pain in her left knee. She landed on her left knee first. She just felt pain, and she tried to keep training through it. I could see her hobbling out there. She came over. She's like, "Dad, something's wrong with my knee." We had a look at it. There was nothing really that we could see with any observation aspects. I did a few quick little tests, and I said, "Well, why don't you just maybe like have a little bit of a walk around on it? If you feel like walking's okay, have a little bit of a jog, see if you can keep training. If not, obviously let's see how you go." So she got on the sideline, tried to do a few things. She was like, "Oh, that seems okay." Got out on the court, and she just started limping more and more and more. And so the pain just got worse and worse. So she ceased training. I did a few exams with her at home. Nothing was showing up clear. The mechanism of injury naturally had concerns for me with that deceleration and how she was complaining about the pain. But from a meniscus point of view, nothing was showing up. From any of the ligamentous stuff, nothing was showing up. We gave her 48 hours, I think, of rest, and nothing was changing. She couldn't sleep at night. She was complaining of pain all night, and I'm like, "I'm not liking this." So we referred her for an MRI of her left knee, as I just couldn't figure out anything on the clinical exam. So this was what came back with the arrow. So we can obviously see that basically the bone bruising, obviously that subchondral marrow edema there. And then, of course, if you get some other views of it, we can see that there's a fracture straight through the bone marrow bruising. And after I saw that, I'm like, well, this makes sense. And night pain, bone pain sucks for any of those in the audience that have had some form of bone pain. So bone bruising, obviously very, very painful stuff. So she had that with a fracture through it. And you go through the process. So we start to think, all right, you got a fracture, you go, all right, non-weight bearing, standard protocols, obviously for fractures, is that we, go non-weight bearing for about 4 weeks, right? We immobilize the affected limb. So process was to go, all right, she's on crutches, we're going to mobilize the knee, but I had access to the laser. So that's how it all started. So the MRI results indicated prominent subchondral marrow edema in the central lateral femoral condyle with a trabecular fracture. So all I did was I grabbed the laser. We'll go through this point and shoot protocol we've talked about the last 2 modules. So I just grabbed that and I just pointed that at, so from our point of view, real simply, if that's a lateral femoral condyle, I was just pointing it at the lateral femoral condyle, point and shoot, and had that over that area for 10 minutes. And I was doing that to my daughter once a day. And I was doing, obviously, rehab progressions with it. So knee range of motion, quad activation, etc., and gradually building her based upon her functional capacity tests. And as you can see on the very bottom statement there, and without exaggeration, so we had her actually doing weight-bearing training on her knee at 2 weeks. We had her back training at basketball at the end of the 2nd week, start of the 3rd week, and she was back in unrestricted competition in 3.5 weeks. And to this day, I sit here and go, yeah, right, that's how we're here today. It really is, because that, as we know, with just fracture healing time, that shouldn't have happened. Even from a bone bruising point of view, bone bruising is a general rule of you're generally going to be in pain for 12 weeks. So applying the laser, because it's not the rehab exercise don't speed up fracture healing. So the only thing we can deduce there is the laser. It's the only thing I can. Some of you guys might have other mechanisms and thought processes there, or hopefully the majority of you are in agreements with me. So the only thing that changed there was me applying that laser, and it accelerated my daughter's healing. So as soon as that happened, that was when I went, I need to understand how this works, because to go from a bone bruising with a fracture in the knee to be back weight bearing playing basketball in 3.5 weeks, it's not unbelievable, but it's very improbable based upon what we know. So that was my moment. And that was when I started to really dive into the literature to try and understand how light therapy worked. And then we'll start to share some more of these case studies towards the end about how we've been able to start utilizing it in different contexts by understanding these mechanisms. So our point and shoot approach, we've talked about this multiple times. So I'm just going to bring up, so in here, obviously, you can see in the middle there, I've got the word pain there, and we can see the frequencies across the top there. We've got 9, 16, 42, 53. And obviously on your slide there, we can see that. The general rule with point and shoot, so once we turn this on, whatever it is that you're doing, so if I've got my hand here, we are just lasering point and shoot, and we want that to be about 10 centimeters away. That's the sweet spot. And then we want the laser to be, in this particular case, we want it to be perpendicular. So I wouldn't want it angled away from the tissues. The more perpendicular I can have it to the tissues that I'm trying to laser, the more photon energy is going to be absorbed. We're going to get the best absorption by having that being done. Your minimum treatment time is just doing that for 2 minutes, but the general approach is about 10. You're going to see across the research here that we'll start sharing is a lot of the research ranges tend to be between like 8 and 12 minutes. So 2 minutes appears to be your minimum. 10 minutes seems to be that sort of commonplace. And then that's our basic point and shoot approach. When we look at some of the Onychomycosis research that already exists, we can see that we have a low back pain treatment protocol where they use 8 20-minute treatments just because the back's such a larger area. 2 treatments a week for 4 weeks, so 8 treatments total, 20 minutes each treatment, and this was a point and shoot. So basically, the other choice that we have is that with this, is as we may be able to see this across my body, is if I have that 10 centimeters, but if I wanted to cover my whole trunk, I can of course move this out to be able to have that being the full length of my trunk. So we could do this for the lower back. So if we said my chest here is my lower back, I could set that to my chest, and then I can just keep that perpendicular, and I can just wand this across my lower back. So I'm pointing and shooting. I'm not doing much else except just covering the area that I want to treat. I'll talk about some things what we call like stacking, or we'll talk about how we can couple things together to try and enhance those therapeutic outcomes. But that there from the Onychomycosis research study was just point and shoot, was just lasering the back, doing nothing else, just putting the laser on it for 20 minutes, twice a week for 4 weeks. And as we can see there, the pain scores decrease of like 36.6 for the laser versus 8 for the sham. So there was a 27.9 points between the low-level laser and the sham, of course, is the LEDs. Plantar fasciitis treatment protocol. Again, we can see here it's a 10-minute treatment application, 2 treatments per week. And you're going to see this is a bit of a common thread that a lot of the treatment protocols tend to be about 2 treatments per week. So this one here was 2 treatments per week for 6 treatments. And all they did was 10 minutes. And this was wanding again. So if we use my hand again, we'll say my hand's my foot for the purpose of this. And that might be the dorsum of the foot. So all they were doing is they were going over the dorsum of the foot, coming underneath to do the heel. Let's say the palm of my hand's the heel. And let's just say my forearm is that Achilles junction area. So that myofascial junction of the heel. So working through that, working through the heel, the dorsum of the foot, and just basically wanding around the area for 10 minutes. So as we said, a point and shoot approach, just using the laser to the area. That's all they did. And again, we can see from that research that got FDA clearance, decreased from 67.8 out of 100 at baseline to 6.9 at the 12-month follow-up. So again, there were sort of positive effects, and they continued to get better after the laser treatment was over. Now, this is a clinical part for us. So if people are purchasing the EVRL and deciding to get that to add this into your practice base. And again, my bias is that I've started to use this a lot more for a lot of different types of conditions, which we'll share. But if you don't start seeing changes, and when I say that, patient may report that to you, but also to your objective measures where you're going back and reflecting things. So if you don't start seeing those changes in about 4 to 6, we're not talking people have to be fixed of what they're coming into, but just seeing that the goals of why you're using that laser or any therapy, we want to see that people are improving. So if you're not seeing signs, objective, subjective, that there's improvements, we want to use this model of start swimming upstream or downstream. And what we mean by that is trying to start to look at bringing in the nervous system. So I'll talk this through and then I'll give you a visual of this on a large screen. So you can see here the frequency settings here are a bit different. I'll talk about those frequency settings on the next slide. So 1, 10, 40, 60. These are based on nervous system EEG, QEEG, binaural beats, resonant frequencies, ultrasound, sound, light flickering, research that's been done with brain. Okay, so these settings, this master brain is what we're going to refer to it as. So the setting, the pain setting that we were using on those previous slides, that 9, 16, 42, 53, the general rule is I'm going to say that from neck, musculoskeletal, neck down, you're going to generally just use that setting. That's all I tend to use is 9, 16, 42, 53. That's what I used for my daughter's fractured knee. When we're starting to go nervous system, so above the neck, and we're going to start to do transcranial work, etc. This is the general master brain setting that I would use for the majority of my applications. I'll share a couple of different ones with you today. So the 1 hertz, the 10 hertz, the 40 hertz, the 60 hertz. And what you can see here is this upstream approach. We're going to have 2 minutes at each area. We're going to go the actual area that is painful, as an example. And I'm going to use the shoulder in my demo in a minute. So shoulder, then you're going to see the ipsilateral nerve root and spinal cord. Easy way to remember it, root, R in the nerve root, root and red, keep the R's together. And then you got over the spinal cord is going to be the violet. Then we're going to stimulate the ipsilateral vagal nerve. Got a slide on that to show you where that research come from about stimulating straight over the SCM. Then you go to the parietal cortex and the prefrontal cortex. So you look at this and you go, well, why are we swimming upstream as it relates to nervous system? So obviously the local area, nerve root, of course, obviously, because that's where that nerve root's exiting for that area, spinal cord, all of that pain integration. So we don't have time to go through the pain modulation, but if we get a chance to do a full weekend seminar coming up, hopefully in the new year, we're going to go through a lot of these details of that, a lot more practical applications. People are going to get a chance to use these devices, feel those things happen to themselves. Obviously, spinal cord, nerve root, stimulating those areas from a pain perspective. Vagus system, the anti-inflammatory parasympathetic effects of that vagus system. I'll share a couple of slides on you with that coming up. Parietal cortex, of course, that's where the mapping of our body parts are. So we know that people that have got pain, especially chronic pain, we get remapping of people's brains. Cortical smudging is some of the words that you'll hear too in the literature. So lasering the brain to correspond to the area. So we want to understand that. We want to understand our homunculus. So our shoulder is going to be out here on the side, arm, face, hand, etc. Upper body is out here on the side of the brain, versus when you get to more the lower back, getting to the hip and leg, that's happening in the midline here. So that sagittal area there. So depending on the area we're talking, the example we're going to use is shoulder. So if I'm going to do shoulder, I'm going to be out here on the side on that parietal cortex. And then of course, I'm going to go prefrontal because of motor control of that area, that volitional control, but also to a lot of my pain mechanisms, autonomic mechanisms through that frontal aspect. So I'm going to stop sharing this for a second. We're going to come back to it. Let's look at this so you can see me in big screen. Hopefully you guys can all see me big screen here right now for the purpose of this. And
thank you.
I'm big screen, and am I?
Yeah.
Perfect. All right, here we go. So if I go, so I've just set my brain setting here. So you guys can see across the top there, hopefully it's glary, but There we go. Hopefully you guys can see those frequency settings there, 110, 40, 60. So I turn this on and I'm going, geez, on the video, it's bad. So I'm going to go 2 minutes over the area, point and shoot. So all of our same rules. I'm perpendicular to the tissue about 10 centimeters away, and I'm just lasering that area for 2 minutes. After the 2 minutes, I then come to the spinal cord. So I'm swimming upstream. Now, obviously, I'm not going to be able to demo this very well from the back. So let's just say you're looking at the back of my spine here now. And we're going to say that if you guys are looking at this, and it's hard for me to see in my own video in reverse, but we would put the violet directly over the spinal cord in the midline, and then the red goes over the nerve root. So if I'm talking about shoulder, obviously the shoulder region, as it relates to the musculoskeletal tissues, we're in that C5 area. So when you put this laser over the nerve roots, you want to be covering that C5 area of the spinal cord nerve roots. So we would then do that for 2 minutes on the appropriate side. After that, we would then go to the vagus system on the ipsilateral side. So if it's this shoulder, I'm going ipsilateral side and I'm going vagus. Now, I'm going to talk to you about stacking. Now, again, pictures here, it's always hard to do this in reverse, but I'm just going mid-belly of the SCM, okay? And I'm lasering the SCM mid-belly for 2 minutes here. All right, so far, directly over the shoulder for 2 minutes, that's my injury of complaint. Then I've gone to the spinal cord level. If it was my leg, depending on where it was in my leg, do I want to hit L1, L2, L3, L4, L5, etc. Shoulder, I'm going C5 as the example. Then I'm going ipsilateral SCM. Then I'm coming to the contralateral. As we know, obviously, this side of the body, that side of the brain, and vice versa, in terms of volitional control, volitional sensation, etc. So then I'm going to come in, and again, got to get myself orientated, and then I'm going to be lasering that parietal cortex for that area, okay? And I'm going to laser that for 2 minutes. And again, trying to be perpendicular, okay? Trying to be about 10 centimeters away for the purpose of video. A little bit tricky, but that's what I'm trying to do when I'm doing it in real life. And then I'm going to go, the last bit here is, there we go, 2 minutes prefrontal, okay, and working on that prefrontal cortex on that side. All right, so 2 minutes on the shoulder, 2 minutes spinal cord, 2 minutes ipsilateral SCM, 2 minutes parietal cortex, 2 minutes prefrontal. So that's basically what it looks like. So obviously over the course of 10 minutes. Let's just come back to this. More of these things I'm going to break out and sort of share with everyone. So that's our upstream approach. And if you have any questions on that, we're happy to go through this at the end with everyone. Now, the frequency applications I talked to you about, this is where it, like, just some research for you as to where it comes from. There's plenty more of this too, but again, not enough time to get through everything in 1 hour. But 1 hertz, this low 1 hertz frequency here, what they've shown with this particular research, they highlight the importance of slow hippocampal cortical oscillatory activity in driving brain-wide resting state functional MRI connectivity. So the importance of 1 hertz frequency, how important that is for our brain. So when we start, I'm not going to get into this all the concepts of teaching you guys obviously about theta and delta and alpha and gamma, etc. But just the purpose of where these hertz come from. Low frequency 10 hertz, vagal nerve stimulation, VNS. The vagus nerve loves 10 hertz. There's a bunch of research on the vagus nerve with this, but they showed that low frequency 10 hertz vagal nerve stimulate activates the cholinergic anti-inflammatory pathway through vagal efferents. And they showed that that helped treating Crohn's disease, both from a brain and a parasympathetic nervous system perspective. Okay, so that 10 hertz frequency. Then our gamma frequency, this 40 hertz. If we start to look at a lot of the research out there, whether it was light flickering at 40 hertz, sound at 40 hertz, laser therapy at 40 hertz, this gamma frequency appears to be very, very important for our brains and in particular as it relates to our neurodegenerative diseases like Alzheimer's, dementias, these cognitive things. So we can see stimulation of gamma should enhance long-term memory capacity. And again, I've got a bunch of studies on those frequencies. And then the last one there, I just used a pain study here to talk about this relationship between this 60 hertz and this 4 to 8 hertz. So people in chronic pain, there seems to be this increased theta activity. So you don't want to be in that range of like 5 to 9 hertz in chronic pain. And this is where you look at this 1, 10, 40, 60 works really, really well. We don't want to be in that theta range there, that 4 to 8 hertz. And they showed that obviously trying to get synchrony in the frontal lobe at that theta and gamma frequencies might be promising targets for non-invasive brain stimulation, neurofeedback approaches, etc. So just some articles there as to where some of these frequencies come from. So it's the pulsing of the light. So just to share that one with you again, so you guys can see, if I just put that on my face here for the purpose of this, and hopefully you can see how that violet light, it's going to go 1 hertz there, 10 hertz now. 1 hertz, 10 hertz. Obviously, you can't see really the difference between the 40 and the 60 on the red because that's 40 flashes in a second and 60 flashes in a second. So it's obviously moving quicker than it's sort of to the visible eye. As we can see here, the vagal nerve stimulation via the neck. There's some studies there that we can see here providing evidence in humans that cervical vagal afferents can be accessed non-invasively via transcutaneous electrical stimulation of the anterior lateral surface of the SCM. You can also get it via 1 centimeter in from your tragus, and you can also get it via the symbiconcha. That's the auricular branch of your vagus nerve in your ear. Chinese med's been doing this for thousands of years. So we've got access to the vagus nerve if we understand our anatomy. And that particular one, nice and easy. We can go straight over the SCM there with our laser to have effects on that. Me being neuro sort of centric, downstream approach. So we can use that master brain setting. And then instead of going upstream, as we said, 4 to 6 treatments, things aren't going the way you want for someone who's got pain and injury that you want healing. We went upstream. We tried here first, neck, SCM for the vagus nerve. We went to the parietal cortex. We went to the prefrontal. So let's flip it around the other way. Maybe now you go downstream instead of upstream. So you can see it again, 2-minute laser application. We go to the parietal lobe, but we're going to stack it now. So while using percussion vibration over the region of pain dysfunction, I'll give you a visual of that. Ipsilateral cerebellum stimulation while we start to use complex movements of that limb to stimulate the cerebellum. Vagal nerve stimulation, we're going to couple that with vagal nerve type breathing to bias the vagus nerve more. And then, of course, we've got our nerve root stuff and then our chief complaint. So the example being here, you've seen what this looks like, obviously on the brain. You don't need the close-ups of it again, but the example being, I'm doing my left shoulder again, as we said before. I'm lasering that parietal cortex. And while I'm lasering that parietal cortex, again, not ideal here, but let's just say I've got one of my percussion instruments here. And so what we could do is we could have percussion going over that side of the shoulder to help map the person's brain further while we're doing that parietal lobe laser stimulation. Okay, so we've got that percussion vibration over the tissue, helping getting that neurological stimulus while we're doing that lasering. Do that for 2 minutes. Then the cerebellum aspect. So we're going to go straight through the cerebellum. So remember, that's living there in that occipital region here at the base of the skull. So contralateral parietal lobe for this shoulder, obviously ipsilateral cerebellum for this shoulder. So I'd be lasering that cerebellum there, base of the skull. And while that's going on, moving the arm in an infinity symbol. The reason behind the infinity symbol is that the cerebellum is going to really, really have to work globally when things are off axis. If you do things uniplanar, After a couple of movements, the cerebellum goes, whatever, move on. When it's off axis, that cerebellum has to keep paying attention, so it drives activity. And of course, from a neurological perspective, too much to cover in this webinar, but that cerebellum, frontal lobe, mapping through brainstem, etc., super powerful for that sort of unvolitional, reflexive understanding of where things are. So, percussion while I'm lasing parietal cortex, ipsilateral cerebellum while I'm doing an infinity symbol, whether it's arm, whether it's leg, etc. Vagal nerve stimulation on that ipsilateral side. So it's obviously this left side again, ipsilateral vagus, and I would do vagal type breathing. So a common one is breathe in for 4, hold your breath for 4, breathe out for 8. So 4, hold, 2, 3, 4, out, 7, 6, 5, 4, 3, 2, 1. And you would do that for 2 minutes. Now, some people cannot do that type of breathing. So how do we bias vagus nerve with that breathing? You just have to double your exhalation rate. So if you breathe in for 1, breathe out for 2. Breathe in for 2, out for 4, etc. So we can do that to try and help bias that vagus nerve. You could hum, you could gargle, you could put your tongue on your teeth, and while you press into your teeth, you could hum, etc., to make that palate move, make that vagus nerve get activated. And then, of course, we go through that same spinal cord nerve root and then directly over that shoulder again in that example we just used. So transcranial penetration, you know, there's a lot of this argument out here as it relates to can light even get through skulls, etc. Well, what we're showing is there's one, a penetration component as it relates to wavelength, but 2, it's these photochemical effects that are creating downstream effects through various tissue markers. As an example, I might have mentioned it in the last webinar that we know that porphyrin in red blood cells absorbs the violet light. So because it's absorbing the violet light, you're transferring the energy along your red blood cells systemically. Really, really fascinating stuff. But we can see here, just as it relates to transcranial penetration, by comparing that distribution, penetration depth, and the intensity of the laser tissue interaction, what we can see there is that 660, so red, and 810 infrared performed better than those longer wavelengths there of 980 and 1064, and 660 was shown to be the best, better than the 810. Then when they did a study recently with the Zirconia, just the red, they used red light, the 635, and it was just continuously moved around the whole skull for 10 minutes. And this was what they started showing on EEG studies. So comparing EEG records before and after the application of the low-level laser therapy, so 635 red, revealed significant activation in several areas of the brain. Brain maps for alpha and gamma absolute powers demonstrated clear increments in 9 subjects. Exposing the brain to 635 laser light for 10 minutes resulted in significant activation of several areas of the brain, was the conclusion. So again, all these references, as you know, they're all there. You guys can go and do this, do your further homework, due diligence on the stuff that I'm talking about, and you can then go and see the details that are within those studies. Again, we're trying to hit the high points here. Just talking about it from LEDs, you're going to see a lot of stuff out there on LED devices, these LED caps that are being used on people's skulls for a lot of this concussion and stroke-based light therapy rehab. First thing I'm going to talk about, which I haven't got here in a slide, sorry, is hair. Hair creates scatter. So unless you're going to shave someone's head and be like me, those LEDs are already losing performance because of hair creating scatter. All right, laser therapy, we don't have to worry about that because of that directionality of the light. But then let's look at this transcranial, can LEDs reach the brain? So this study from 2015, which was a review study of a bunch of articles, any LED device showed no photonic energy transmission through human skin. That becomes interesting, right? But again, we know the argument, we know they work because of course, whatever light is being absorbed is having those photochemical effects, okay? But as it relates to penetrating, like we want this to get into obviously brain tissue as well. So you can see those different wattages of the different wavelengths there. So an 810, so an infrared LED did not appear to penetrate 1.9 mil of human skin. We can see there is 650, so a red visible light, and an 880 infrared LED. No energy was detected in that sort of thickness of human skin. LED did not penetrate 3 centimeters through air or brain tissue. No detectable energy in a red or infrared LED system could be detected at 3 centimeters through air or tissue. 6-watt LED showed a 99.995% drop in power density across 3 centimeters of tissue. And this is where the important part comes. We said biphasic dose response, yeah? We said we needed enough energy to get into tissues to create that biostimulation, hormesis, yeah? We didn't want to get to the point and then come crashing down for bioinhibition and detrimental effects, but we needed to have enough stimulation. So extensive research has shown that within the range of 0.9 to 15 joules per centimeter squared is most effective in activating the biological processes involved in reversing or mitigating the pathophysiological effects of TBI. So when we're looking at brain-based studies, we know that we need to be getting, like, say, 1 to 15 joules per centimeter squared. 15 is the absolute upper limit. When we look at a lot of the research, 10 really starts being the cutoff, but obviously this research, so 15 is your cutoff. But I'm going to suggest to you guys 10 based on a lot of other research. And they show that using a 0.5 watt infrared LED, the estimated energy reaching the cerebral cortex is 0.0064 joules per centimeter squared, which is 1/140th of the minimum thought to be necessary for ideal photobiomodulation. So if we're going to use tools, we want to use tools that we know has the evidence to create the therapeutic effects that they say it's going to. So let's look at a couple more clinical applications. We've already talked about that neck shoulder pain treatment protocol. We can see that in that, this study by Onychomycosis almost had a bit of that downstream type of approach. They lasered the sagittal suture, the top of the head. They then worked down the ear and the muscles here into the shoulder. They then did, obviously on the other side, they then started moving the arm for a minute while they did the front of the shoulder. They then did the back of the shoulder while they moved the arm. They then did the neck while they were bending and moving the head, and they repeated that on the other side. So a 13-minute treatment protocol, very much like a downstream from the brain down to those tissues. Now, this one here, I've got a couple of cases going on with this myself right now, but you can see here, toenail fungus basically is the treatment protocol was 1 treatment for 4 consecutive weeks. So 4 treatments total, exposure time of 12 minutes is basically laser across the toenails. And this was done with a specific, so Reha Care has been selling this device, the Lunular Zirconia device. But again, it uses the exact same wavelengths that are in this. So you can use this exact device for this particular protocol. Again, I've got 2 cases of this going on right now. First treatment was last week. Second treatment was done today. This was a case that has said that she's done everything, has tried all the different sterile socks and shoes and changing all that, obviously medications, creams, all the different podiatry interventions, etc., without any success. And after 1 treatment, so I saw her for the second time today, she'd already said to me that her toenails have not been flaking. Now, when we look at the research behind it, the onychomycosis decreased from 23.9% at baseline to 13.9 at 36 weeks. You can see here, it's a long process for this physiological effect because you're waiting for the toenail to grow. That's what we're actually waiting for. And what they showed here, 62% had achieved completely clear nails in 36 weeks. All right. Each parameter showed further improvement at 48 weeks with no evidence of reinfection following 4-week treatment. So after a treatment each week for 4 weeks, that we saw that the toenails were getting clear just by applying that laser. And again, this is one that I've just started trying myself in a case as of last week. And again, she's reported already that, again, she reported to me today that that's what she said. We'll see what happens after 4 weeks and then following up 36 weeks, 48 weeks. This laser is pre-built with an Acne protocol. So if we go to the home here, if you guys can see that at the very top, you'll see there it says Acne up the top. And so Protocol for this, as you can see there, applying 12 minutes of continuous violet laser to the entire jawbone area using a sweeping motion. So we just wanding it. Let's show you that just real briefly. So wanding this over that jawline for 12 minutes. And then after you've done your continuous wanding over the jaw, you would then do that obviously over your forehead, eyebrow area for another 12 minutes. Again, you hold that 10 centimeters away from the tissues. And again, it's 2 treatments per week for 4 consecutive weeks, total of 8 treatments. Now, again, all the things that we're sharing with you here, these are all the ones that have got FDA clearance to say that, yes, this does work for that. Okay. Now, I wanted to share this one with you is peripheral nerve regeneration, because I think this one's fascinating. The general rule with nerve regenerating is 1 millimeter a day is nerve regeneration. But what they showed here is, we'll just come back to here, is photobiomodulation was able to accelerate the process of nerve regeneration. There's been nothing that's been shown to do that. You can only decrease the regeneration rate, is what the research generally says, presenting an increase in the number of myelinating fibers and a better lamellar organization of the myelin sheath, besides improvement of electrophysical function, immuno, et cetera, et cetera, et cetera. It was concluded that photobiomodulation has beneficial effects on the recovery of nerve lesions, especially when related to a faster regeneration of functional improvement, despite the variety of parameters. And this is what I want to show you, that in the frequency, this is a systematic review using all different types of light therapy on peripheral nerve regeneration. Some people used it every day. Some people used it every second day. Some studies used it 3 times a week. Some used it for 1 minute only, up to 9 minutes. Some people just treated them for a total of 1 week, up to 3 weeks. So you can see all of these different parameters, but it's all about that absorption and accumulation of the light therapy. So what we're seeing here is, despite that variety of parameters, we can see that there were improvements in that. And again, all of those studies for that, all it was pointing and shooting it at the area of where you were trying to get that nerve regeneration. So you would go, let's say that the injury happened here at the elbow, you obviously be doing that at the elbow. And then from our point of view, we would then start going up and we would start thinking about, let's get that nerve root, because that's where the actual cellular process is going on, sending that axon regeneration back down is happening from here. So hitting that area, hitting the spinal cord. Now, I wanted to share this for a number of people that are online that I know deal with some stroke stuff. So we've got some stroke studies, traumatic brain injury studies there that I've just referenced for you. But what I did there was just to show people the sort of approach that myself and some colleagues would do as an example, not for everyone, but as an example of how you might use laser therapy in conjunction with a bit of a stroke rehab protocol. So you can see there the 110/40/60 to the ipsilateral vagus nerve. You then laser the cortex of the involved site. So the stroke happened here, lasering the cortex for 2 minutes on that side, and then the contralateral cerebellum. And while you're lasering them, have the person visualize the desired movement of the affected limb that you are trying to rehab. Do that with their eyes closed. Then we talked about activating the frontal lobe with appropriately directed saccades. Sorry guys, I'm going at a pretty big clip here because I realize I'm already over time and I want to get to these last case studies for you. But you got all this here as a little reference to come back. Mirror therapy, for those that don't know how to do it, there's lots of stuff you can go and look up on YouTube and Google and go and do courses on this. But I've just spelt that out there. Basically, put a mirror in front of a limb. If this is my limb that's had the stroke and I can't move it, I put the mirror in front of it. I've got this arm over here, but I'm looking in the mirror, and my brain, because it's looking in the mirror and it sees this one and it sees this one moving, my brain, as brilliant as my brain is, it confuses it and it thinks that the arm behind the mirror, which I can't see because the mirror is there, when I move this, my brain actually thinks my stroke arm is the one that's moving in the mirror. And then we can start to build that. We can start to have them use their good limb in the mirror. Then we can start to move their limb passively to mirror the good arm with the movements they make. We can start to get them to build it to active, etc. And then our concussion-based type protocols. So someone who's had an acute concussion in less than 4-week range, we've got acute brain settings. And again, this is about the only other settings that I sort of really use. I've got a delta wave like 111 or a 110, 110 is these types of frequencies depending on the person I'm seeing. And you can see here, this process, and why I want to share this with you is this is the case that's about to come up of just lasering prefrontal cortex in the acute stuff, frontotemporal, which is like, so frontal temporal basically just hitting the whole side. I don't know if you guys can see that. I've got the violet only on in that case. So frontal temporal, 2 minutes each side. That's your 4 minutes total. Then you've got your 2 minutes vagus to the SCM. And then what you can do with that is also to get further aspects of vagal nerve stimulation, which is to then laser it over the abdomen. All right, so I'm lasering and wanding over the abdomen to get those vagal stimulation through the stomach. And you can see again, giving you that protocol there from the literature of 3 times a week for 2 weeks and then 1 time a week until symptom resolution. But then the chronic phase, so people that have had stuff for longer than 4 weeks, we go back to our master brain setting. We've got prefrontal cortex, 2 minutes there, point and shoot. All right, simple at the front, sorry. There we go. 2 minutes at the front, point and shoot. 2 minutes apical, 2 minutes brainstem, base of the skull. Then I've got vagus, vagal stomach. Now, anything that's chronic, we're going for about 10 to 12 treatments. But again, we want to see changes occurring in about 4 to 6 treatments objectively. I want to show you guys really briefly this case study just to show you, I guess, how amazing you might find some of the things that laser can do. So Tony is a colleague of mine, works in the neurospace. I'm going to end the presentations there. From my perspective, the rest of my presentation is just the references and the slides.
And once again, thank you very much, Brett, for your time. You're an absolute stunning presenter, and I think we've all really appreciated it.
Appreciate that, Anne. Thank you.
You're welcome. Thank you. Good night. Have a good evening, everyone, and thank you very much for joining us.